السلام عليكم مرة ثانية. الصوت مسموع والسلايدات واضحة. طيب، الموضوع الأول اليوم we'll talk about how to approach and manage leukemia and lymphoma. طبعا these are the objectives, and the objectives here are important for us because the topic is wide, honestly, and can be complex and beyond the level of, let's say, undergrad. So we're gonna try to focus on certain things in the topic, including a medical oncology emergency, how to recognize lymphoma and leukemia, and how to approach them, to stage them, as well as when to call the specialist. Okay. So at least two oncology emergency we're going to talk about today. One is structural urgency and emergency, and we're talking about examples like superior vena cava syndrome, spinal cord compression, as well as metabolic urgency like tumor lysis syndrome and hypercalcemia of malignancy. So the first one is the superior vena cava. And as you can see in this gentleman, some people will present with distended neck vessels. So you'll see the GVP is full and gorge, okay? As well as you're gonna see a dilatation of the peripheral veins, as you can see it here. And this is usually of tumor originated from the lung compressing the superior vena cava. So there is going to be a backflow in the venous system, causing the congestion in the GVP, fullness in the GVP, as well as the dilatation in the peripheral venous system. That's been said, this is also can happen from a lymphoma because the lymph system also present here, whether in the neck or in the mediastinum area, and also it can compress the superior vena cava. So what's the treatment for the superior vena cava syndrome? It's basically treating the underlying causes, okay? And if there is any thrombosis, if there is any clots from the stasis of the blood within the vessels, that will require adding an anticoagulation. Surprisingly, the presence of SVC syndrome doesn't affect the mortality that much, okay? Okay, so the second type of medical emergency should be recognized is spinal cord compression. And this has happened when the tumor, usually metastatic nature, compressed the spinal cord and result of neurological deficit, okay? So what are the common causes? Well, any metastasis, especially from lungs, breast, prostate, myeloma, as well as lymphoma can lead to such complication, okay? And what are the symptoms? Usually there is a pain, like back pain, preceded the neurological symptoms. So this is actually a key. When you have someone complaining of back pain, and then after days or weeks started to have a neurological manifestation, that should be considered as a red flag. What is the image of choice? Well, whenever you can do an MRI, it's probably the best choice. How to treat those situations? Well, you give them high dose steroid to try to reduce this swelling, as well as involving a neurosurgery or sometimes orthosurgery, depend on the institutes for surgical intervention, as well as radiation therapy toward that tumor. Okay. The third complication or urgent medical metabolic oncology emergency is the tumor lysis syndrome. And this is a result of when the cells basically get ruptured inside the vessels, okay? And this is usually a result of dying a cell, basically. So when the cells die and ruptured within the vessels, started to basically uh, raising some of the electrolytes in the blood, because each cell is containing a blood, so those electrolytes will be free, including potassium. So there will be a state usually of hyperkalemia, phosphorus. There would be a state of hyperphosphatemia, as well as the uric acid. Well, we know potassium is lethal, and hyperkalemia can kill uh, as it's causing cardiac arrhythmia, as well as the phosphorus, okay? And the uric acid can cause kidney injury in form of kidney stone, or in form of acute kidney injury, okay? And can be a result of the disease itself, like spontaneous, but also can be induced by the treatment, okay? So by giving treatment like chemotherapy, that's mainly to the tumor lysis to begin. Okay, so what are usually the usual suspects? Which kind of malignancy, because it's from its name, usually it's tumor. Huh? What kind of malignancy can lead to tumor lysis syndrome? Well, usually it's the highly proliferative hematological malignancy like acute leukemia or high-grade lymphoma. How to manage them? Well, first, they should be in cardiac monitoring because they are prone to have cardiac arrhythmia, whether from hyperkalemia or hypocalcemia. Second, hydration, hydration, hydration. Third, monitor the electrolytes and the creatinine closely. Fourth, allopurinol for intermediate risk, and respiricase for high risk. And why we are giving those treatment? Well, basically to prevent the DNA material to go into a toxic material. So we know that uric acid is a toxic material, so we don't want the DNA DNA, of course, coming from the cell to reach a form of uric acid. So what we do is try to block xanthine oxidase. So that's meaning the DNA material will remain in a form of hypoxylxanthine or xanthine, which is less toxic than uric acid. The other choice is to give the respiricase, which basically transforming the uric acid to allantoin, which is highly urinary excreted and less toxic than uric acid. Okay, and this is a summary for the tumor lysis syndrome from the characterization, the definition, as well as the management. This is a very useful website for you guys to look at. It's called The Intern at Work. It has a lot of a handful summary for medical conditions. Okay, so the fourth medical emergency is the hypercalcemia, okay? And hypercalcemia can be secondary to malignancy, but given that we are talking about leukemia and lymphoma, we are interested in particular of lymphoma, which can cause hypercalcemia by overproduction of vitamin D, okay? How to treat? Well, they should receive aggressive hydration to get rid of this calcium. Calcitonin and bisphosphonate should be considered. Loop diuretics are only recommended for those people started to have heart failure. Okay? Okay. Any question, guys, about the oncology emergency, the four we talked about? Whether 3C syndrome, tumor lysis syndrome, hypercalcemia, or spinal cord compression. Okay, no question. So now we're going to go to a more complex صراحة topic, and we'd like to take our time in this, okay? So leukemia's rearrangement, okay? So it used to be that the leukemia being basically categorized to two types, whether acute, chronic. And the acute is acute myeloid or acute lymphocytic, and then the chronic is chronic myeloid and chronic lymphocytic leukemia. But recently, there was a rearrangement for that, because they found that this categorization doesn't reflect the tumor correctly, okay? So the acute leukemias remain the same, so they are still within one category, but the chronic one deviated from the leukemia. So the CML, the chronic myeloid leukemia, now considered as part of the myeloproliferative neoplasm, okay? While the CLL, the chronic lymphocytic leukemia, now considered one of the lymphoid malignancy, okay? So myeloproliferative neoplasm consider the CML consider part of that family, including essential thrombosis, polycythemia vera, PMF, while the leukemia, we know AML and ALL, lymphoid malignancy, including lymphomas and CLL. This is just a rearrangement to reflect which malignancy can put together, as they are sharing a lot of clinical presentation or even genetics similarity. So acute leukemias. The definition for them, as you can see, is an infiltration of a bone marrow, blood, and other tissue by uncontrolled proliferation of abnormal delayed differentiation of colonial myeloid or lymphoid precursor cell, exceeding 20% of bone marrow or blood. The definition is a little bit complex, but if we're gonna break it down, notice that there is an infiltration, okay? So there is an occupation of someone from outside or from someone shouldn't be there. And this infiltration can be in the bone marrow, can be in the blood or other tissue, okay? So it doesn't have to be in the blood. Sometimes you will have blood doesn't contain leukemias, but the bone marrow still may contain some leukemia. So the absence of the leukemic cells in the blood doesn't rule it out, okay? Okay, so AML typically manifested as anemia, thrombocytopenia, and functional neutropenia. The reason is the following. The leukemia cell, which is basically is not functioning cell, is infiltrating the bone marrow. And guess what's being produced in the bone marrow? Well, we have RBC, which reflects in the anemia, thrombocytopenia, the platelet, which reflect as thrombocytopenia, as well as functional neutropenia. Can you guys give me 1 second? Okay, sorry for that. I'm on call. So the manifestation are anemia, thrombocytopenia, functional neutropenia from the infiltrated bone marrow, but the clinical presentation would be reflecting as petechiae, epistaxis, this is from the thrombocytopenia, symptoms of anemia, you guys know about what anemia can cause, or how can it be reflecting in form of symptoms, as well as infection from the functional neutropenia. Functional neutropenia meaning you have white blood cell, but they are not actually functioning. Okay. Myoplastic are usually seen in the blood smear, but may be absent. Okay, but you will find it in the bone marrow biopsy. What? When we treat leukemias, the goal of the treatment is really to ablate يعني مسح, ablate the bone marrow to eliminate the blasts, and this will cause transient destruction of the normal hematopoietic cell as well. So بالعربي احنا نعطي الكيموثيرابي, it will kill the bone marrow, but it will kill both the bad guys, which is the leukemia, as well as the good guys. But the good guys, this will be transient, basically. They will recover after time, okay? But during this recovery phase, you may have a sort of aplasia. There is no cells being produced, and it can take up to 4 weeks for the recovery. So during that time, you will have to support the patient with transfusion because they may become anemic, antibiotic, and transfusion even for platelets if needed, as well as antibiotic if they have, for example, infection. Is this clear, guys? This is a very crucial and critical. ممتاز. طيب, let's take a case. A 38-year-old presented to the emergency with fever, epistaxis. He's been experiencing malaise for several weeks, fever and chills and anorexia for the past 3 days. And now he developed epistaxis. On physical examination, temperature is 38.8, blood pressure was 105/70, pulse of 110, wrist rate of 24. He appeared diaphoretic. He has a dry blood noted in his nares, and gingival bleeding is present. No lymphadenopathy or hepatomegaly was noted in examination. He has petechiae bilateral in the lower extremities. So how would you investigate this patient? We talked about history as well as management. What would you request for him? CBC? Okay. So the CBC showed the following. His hemoglobin was 98, so he is anemic. His platelet was only 17,000, so he had thrombocytopenia, and his white blood cell was 3.6. But look at the differential. He has only 20% neutrophil, and he has actually 18% atypical cell. Atypical cell, also called blast. His APT is 24, so prolonged, as well as PTT is 60, prolonged. And the fibrinogen is 93, it's reduced. And you guys see the blood film here? Do you guys see this cell? This is abnormal. This is not normal cell. Anyone know what's the diagnosis? Okay. But this is what we call ABML. Okay. And this is a kind of subacute or subset. It's not actually subacute, subset of AML that often presents with bleeding and coagulopathy. So if you remember this case, he has some features to suggest that he is actually in DIC. The thrombocytopenia, he's having the prolonged PT and PTT, all are suggesting of DIC, okay? And this should prompt transfusion with fresh frozen plasma or cryo, in addition to the platelet transfusion for thrombocytopenia, okay? How to treat those cases? Well, we give them induction phase of all transuranic acid, and then consolidation phase usually is chemotherapy, and then you may end up needing some maintenance phase, okay? Guys, look at the picture. You guys see this? اللي جنب النيوكليوس here كذا كأنه عصا. This is what we call iron rod, okay? Stick-like, yes. This is what we call iron rod, which is actually pathognomonic for ABML, okay? Okay, so how about the AML? So ABML is a subset, يعني نوع من أنواع AML, but AML, to treat AML, usually you will have an induction therapy, anthracycline, and infusion cytarabine, okay? Again, the goal is to ablate the bone marrow and eliminate the blast, and then try to support your patient during the period of ablation. Okay, this is another just summary how to approach blast in blood. So first, you recognize the blast, you get the smear to know what kind of malignancy you are facing, and then look for medical or hematological emergency like cytopenia, tumor lysis syndrome, DIC, febrile neutropenia, as well as leukostasis. But case 2, a 27-year-old female seen in the primary care clinic. She feels well. She has a history of ALL, diagnosed at age of 5. She received treatment for 2 years and has been leukemia-free since completion of therapy. She takes no medication. طبعا, this is just a message that ALL usually is affecting children. Okay, someone is talking about attendance. Shall we take a 5 minutes break and come back instead of losing you guys or losing your attention? Okay, let's regroup. لا تطولون علينا ها. 5 دقائق. طيب السلام عليكم مرة ثانية. فخلينا نكمل الموضوع على السكند case. So we talked about someone basically now she's 27, had ALL at age of 5. She's been leukemia free since then. Physical examination was basically unremarkable. Vitals, BMI of 31. Other examination findings are unremarkable. CBC performed the past year and were normal. Okay, so how would you manage this cancer survivor? Well, the point I'm trying to raise in your head that actually adult survivor, because I'm talking about as someone dealing with adult more than a pediatric age group, adult survival of childhood leukemia at higher risk of secondary cancer. So this is why we continue doing a screening, as well as for cardiovascular disease and metabolic syndrome. Okay, this patient already obese, BMI of 31, so we will have to check for lipid profile, as well as fasting blood sugar and maybe a hemoglobin A1C, as well as we may consider doing an echocardiograph every 3 to 5 years. Okay, so we are basically trying to recognize the risk factor for coronary artery disease early on in those individuals to try to detect them and to try to control them. Okay, now let's talk about lymphoma, which is actually a bigger topic and more branches than the acute leukemia. Okay, so the lifetime risk of developing non-Hodgkin lymphoma is 2.1%. Okay, that's meaning يعني from each 100 people, roughly 2 of them they're gonna end up having non-Hodgkin lymphoma يعني at one point of their time. So it's a very, very common disease. Okay, you can see the relation between the non-Hodgkin lymphoma with age. You see it goes up with age. Is that right? كلكم تشوفون هذا؟ يعني is it clear to say non-Hodgkin lymphoma risk increase with age? بيسمع منكم yes, no, yes, okay. How about Hodgkin lymphoma? So what do you guys see? So this is age. يعني this is babies, this is elderly. Is it going up with age, going down with age? So what this shape look like? Okay, this is what we call, guys, bimodal. Okay, so it have, instead of one peak, it have 2 peaks. Okay, so you guys see the first peak here, so basically in the 20s, and the second peak is basically here around the 50s, 60s. Okay, so this is what we call it bimodal relation. Okay, so not one peak, 2 peaks. Okay, so most of these cases with lymphomas are seen to be sporadic. Okay, that's been said, there is some familiar clustering, so you will see some sort of lymphoma runs in a family. Also, patient with immunosuppression, whether it's congenital or acquired immunosuppression, they are at great risk of a lymphoma, as well as viral infection, also associated with increased risk, and we'll take some examples for viral infection. So EBV are associated with Burkitt lymphoma, while HTLV1 associated with T-cell leukemia and lymphoma, and from its name, I think that's clear. Hepatitis C virus also increased the risk of lymphoma, especially splenic lymphoma. Okay, HIV also increased the risk of B-cell lymphoma, Kaposi sarcoma herpes virus from its name, increasing the risk of Kaposi sarcoma. Okay, so enlarged lymph nodes are the most common sign of lymphoma. Okay, so whenever you are suspecting lymphoma, you have to do a thorough lymph node examination to try to find the site where the lymphoma is originated from. Okay, CT are very useful for evaluation. So usually we do CT chest, abdo, pelvic to assess the non-palpable lymph nodes that you cannot detect in physical examination. Also, it will help out with the staging. When it comes to the evaluation, whenever you are suspecting lymphoma, excisional biopsy, taking the whole thing out, is often prepared to a core needle biopsy, which is better than the FNA cytology. Really, the FNA cytology and بس cytology usually is inadequate. Okay, so when you're suspecting lymphoma, it's better to get excisional biopsy, or if that's not feasible, maybe a core needle biopsy. The reason they need to do a lot of staining and genetic testing. So FNA cytology wouldn't be adequate for that. When it comes to the classification, it's not only relying on the histopathology staining anymore, okay? Not only that, so histopathology is still important, but it's not the only things important for classification. So usually we end up doing what we call flow cytometry, immunohistology stain, cytogenetics, as well as molecular genetics. So with time, this has become very complex process. And for that, we have tons of types of lymphoma. We're going to talk about them shortly. This is the staging system, which is actually still valid. Basically, stage 1 is you have it localized in one area. Stage 2, you have it in 2 different regions, but the 2 different regions still whether above or below the diaphragm, so whether above or below. Once it's crossing the diaphragm, like here, this is considered as stage 3. Stage 4 is basically disseminated and going beyond the lymph node system. Okay? Staging for lymphoma, certainly including physical examination as well as CT scan, as well as PET scan for most of patients. In the past, before the PET scan era, they use actually to do laparotomy, or they basically doing laparotomy for the abdomen, trying to find lymph nodes, as well as for some people they will do splenectomy. This is all for staging, and this is not the case anymore. As well as bone marrow. Sometimes they don't need even the bone marrow aspiration. So these are the types of non-Hodgkin lymphoma. It's very, very complex, and it's getting more complicated with time, basically, okay? So you have low-grade indolent, you have high-grade aggressive, you have virally associated, you have B, and those are B-cell, you have also the T-cell lymphomas. Okay, but بالمثال يتضح المقال. Let's take examples. 75-year-old male evaluated for lymphadenopathy. He is otherwise asymptomatic, taking no medication. On physical examination, vitals are normal. There is a generalized lymphadenopathy with a nodes 1 centimeter to 2 centimeter size in the inguinal area bilateral. Okay, no hepatosplenomegaly. Okay, so CT scan for the chest, abdomen, pelvis showed retroperitoneal nodes that are 1 to 2 centimeter in size, labs including CBC, biochemical, LDH level were normal, serum urate level is normal basically, left inguinal node biopsy showed follicular lymphoma. Okay, so you heard the story, you saw the physical examination and the assessment. So what do you think the best management for this patient? Have a guess, guys. يعني, what's your gut feeling is telling you? Okay, we have chemo, chemo, chemo. Okay, we have a lot of chemos. يعني, that's intuitive answer, huh? And this is one of the reasons why I put this case. Well, this patient need observation only. This follicular lymphoma is indolent, slow growing, and usually not gonna cause a lot of problem, okay? So you'll ask yourself, we have lymphoma and we're not giving any chemotherapy or removing? Yes, because we know it's slow growing. So instead of giving them those toxic chemotherapy, we basically monitor them clinically. And once it's become symptomatic, whether symptoms, I mean like B symptoms, like fever, weight loss, or the bulkiness, nafsu, it's starting to cause a problem. For example, if he has it in the neck, it may cause shortness of breath or any respiratory symptoms. At that case, we'll opt to treat. But sometimes observation is a reasonable option, okay? Especially in slow growing tumor like follicular lymphoma, okay? And there is no clear evidence that early treatment will improve the outcome. So asymptomatic patient without bulky disease usually are observed, okay? But once it's become advanced stage or the bulkiness started to affect their life, you may consider giving them rituximab as well as chemotherapy, and can lead to remission up to 90%. Although most of these patients, the disease will recur. Okay? Okay, any question? So the take-home message, not all lymphoma require treatment. Some of them observation is an option. It's depend on the, of course, the tumor itself. If it is aggressive, if the aggressive type, they definitely will need treatment. If it is indolent or slow growing, observation might be an option. Chronic lymphocytic leukemia, so I lump them with the lymphoma here, generally very easy to diagnose because it's usually manifested as absolute lymphocyte count being elevated. So you take a CBC, you will see white blood cell is 30,000 or 40,000. Okay, a differential حقة mostly are lymphocytes. You know this is likely a CLL disease. Anyone knows what those cells are? Do you want to cells دولي؟ هذول اللي نسميهم smudge cells. The lymphocytic leukemia cells are very fragile. So when they put them in slide, they actually basically ruptured and crushed. Okay? Okay. ايش كانت اصلا CLL, they were actually lymphocytic leukemia cell. اللي يسأل إيش كانت أصلا. So they're actually cells, lymphocytes, but they are leukemic in nature and they are very fragile. So when they put them in the slides, they ruptured. كأنه واحد كده طاعجهم. Usually we need flow cytometry using the peripheral blood to establish the diagnosis and also to reveal what kind of antigen in those cells, okay? Usually CLL is indolent. Again, it's a very slow growing disease. Many patients will require no therapy for years and sometimes even for decades, okay? That's been said, there is an advance in the treatment of CLL. These therapy are not to cure, but to actually provide a durable remission. Okay, so احنا نبيهم بس to be in a state of remission. Okay, this is just an algorithm to tell you how complex those diseases can be. So CLL, if they are naive, يعني ما قد naive meaning that they never received a treatment for that disease. It's dependent on the genetics testing. They may end up requiring oral agent or sometimes chemotherapy, depending on the situation. But if they are actually previously treated, you will see that this has become more complex and they will be more aggressive. Okay. Pay attention that people with CLL are prone to infection. And this is in part related to the commonly associated hypogammaglobulinemia, okay? And for those patients, we may consider giving them gamma globulin regularly to reduce the infection event. So we give them IVIG, okay? Okay, case 4, 23-year-old male evaluated for a mass in the left side of his neck. He has experienced some fever, night sweat, and unintentional weight loss. Take no medication. Physical examination, all vitals were normal. There is a left supraclavicular lymph node enlarged to 4 centimeters, as well as axillary lymph node is noted bilaterally. There is no hepatomegaly. Biopsy specimen from the supraclavicular lymph node revealed Hodgkin lymphoma. Laboratory results including CBC, biochemical, LDH are normal. CT and PET scan showed mediastinum lymphadenopathy with node up to 4 centimeters in size. There is left supraclavicular and bilateral axillary lymphadenopathy. So at least they have stage 2. It's in 2 different sites, and no infradiaphragmatic disease is observed. Okay. So how would you proceed managing this patient? Well, all patients with classic Hodgkin lymphoma, regardless of the stage, receive chemotherapy. Is this clear? This is a very general statement. If you have classic Hodgkin lymphoma, you are qualified to receive chemotherapy. Okay? For patients with early stage and favorable disease, this is based on the cytology results, treatments may consist with a short course chemotherapy as well as field radiation. So إذا كان الكيمو إذا كان Hodgkin lymphoma very contained one area وكل cytogenetic testing are favorable, they may require short course of chemotherapy and radiation instead of full course chemotherapy. Okay. أعتقد خلصنا الآن. Do you guys have any question? About leukemia or lymphoma? ما زلتوا معانا شباب ولا؟ Someone is asking نحفظ أسماء الأدوية بسلايد 55. No, I don't expect you to know the chemotherapy والأشياء هذه. That being said, it's reasonable to know which chemotherapy being given for each malignancy. بس يعني النيمز R-CHOP. اليوم تكلمنا عن ال AVB. يعني بس to know them, to get familiar with. دكتور A2 يرجع في أي عمر. It can happen at any age. ما في عمر معين. But usually they will, if they're gonna recur, usually they will recur earlier. Okay. But also people with cured ALL, they are at risk of other malignancy, not only recurrence of ALL. So they are at risk of other malignancy, other cancer. Okay. So I know it's been a long lecture. So let's group at 9:15, 9:15. Allah يعطيكم العافية.